My name is Dr. Agbetoba. I am a fellowship-trained rhinologist and skull-based surgeon. I practice in Houston, Texas. My practice primarily comprises of advanced chronic sinusitis patients, as well as patients with a variety of skull-based disorders. We will be presenting a case study of a 52-year-old male with a long history of chronic rhinosinusitis. The patient had undergone prior endoscopic sinus surgery procedures involving traditional endoscopic sinus surgery in the OR setting, as well as an in-office balloon sinuplasty procedure. Despite this, and multiple rounds of oral antibiotics, systemic steroids, saline rinses, and intranasal steroid sprays, he persisted to have symptoms of headaches, postnasal drainage, as well as loss of smell. Subsequent CT examination did demonstrate near complete opacification of both the left and right frontal sinus cavities, as well as some disease involving both the anterior ethmoid and frontal recess cells. Nasal endoscopy demonstrated lateralization of bilateral middle turbinate remnants. This led to obstruction of the frontal recess. There was also noted to be bilateral mucopurulent drainage, crusting, and significant Synechiae formation. Intraoperatively, the patient was noted to have significant narrowing and stenosis of the frontal recess. Again, there was noted to be mucopurulence and Synechiae formation. Given his long history and propensity to scar down and close off, decision was made to perform an expanded draf 2B approach. With use of an endoscopic drill, the AP diameter of the frontal recess and frontal beak were widened. This allowed for an optimal frontal sinus and neofrontal sinus opening. After completion of the draf 2B frontal sinusotomy, traditionally I would have placed an intraoperative contour PROPEL stent in both the left and right neofrontal ostium. However, given our increased access to in-office use for the PROPEL device, my decision was to wait until the first or second postoperative visit, dependent on the degree of inflammation. My thought process behind in-office placement was to deploy the device in a setting of reduced inflammation, meaning less tissue edema, less crusting, less mucopurulence, and less bleeding. At the patient's second postoperative visit, the patient was known to have minimal edema, no Synechiae formation, and minimal crusting. The contour PROPEL stents were found to be in excellent position. This was a very interesting case in light of the patient missing multiple postoperative visits secondary to both the COVID pandemic and the patient himself contracting COVID. I truly believe this was an unforeseen advantage. The 2-in-1 mechanism allowing for mechanical spacing and localized drug delivery, I believe may have prevented restenosis, Synechiae formation, and the need for potential additional surgeries. At the patient's third postoperative visit, 1 month removed from the surgical date, the patient was noted to have very minimal tissue edema, no crusting, and again, no Synechiae formation. There was no signs of any stenosis, and again, the contour PROPEL stents were found to be in excellent position with minimal adjacent crusting. At the patient's fourth postoperative visit, now 3 months removed from the surgical date, the neofrontal ostium bilaterally were found to be widely patent. No evidence of mucosal edema, Synechiae formation, or evidence of restenosis. The contour PROPEL stents themselves have been degraded and/or debrided. Chronic sinusitis is a chronic inflammatory disorder. Steroids are immensely helpful. So the idea of us placing an implant that will release steroids over a period of 4 to 6 weeks, but minimizing the side effects of systemic steroids, I think is a significant advantage for patients. At this 3-month follow-up, the patient reported resolution of his sinus headaches, postnasal drainage, as well as his nasal congestion. For patients with chronic sinusitis, with true chronic rhinosinusitis, there are so many different variables in place. We all know it's a very heterogeneous disorder, and so trying to predict how one patient may heal versus another can be very, very difficult. Even in patients with nasal polyps, there's a wide spectrum. So I really like the idea of an implant, a steroid-releasing implant, as insurance in many cases. Anytime I'm doing any type of formal frontal sinus dissection, when feasible, I like placing the contour PROPEL stent because you never know what patient is going to be prone to Synechiae formation or stenosis. Some patients may have moderate disease, but may have a propensity for scar formation, whereas others may have very severe disease, but may do very well without placement. And so trying to decide who to place it in can be very, very tough. One of the advantages of now being able to place it post-operatively is that if you don't feel comfortable, or if you feel like you would like to avoid placing it in the operating room, you now have the advantage of placing it in the office setting. If you see someone who has increased edema in the frontal recess, or increased edema in the ethmoid cavity, or maybe their middle meatus is becoming a little bit more narrow and their middle turbinate is somewhat lateralizing, now you have the option of placing a PROPEL stent in the office so that we can combat the edema, we can combat the inflammation, and then we can allow for mechanical spacing of the delivery device or of the PROPEL stent. Tissue and wound healing can be very unpredictable in this patient population. We all know that the sinus cavity that's most likely to stenose is that frontal recess and that frontal neo-ostium. So for me personally, any type of formal dissection involving the frontal sinus, I am most likely going to place a contour PROPEL stent. Whether that's in the OR or in the in-office setting will be patient dependent.